we'll put a link to that recording in the same place on the ANZONA website. So next to each session you see what the link is to get into it, and then also what the link is to listen to the recording if you don't get a chance to listen to it then. Other questions? Oh, excellent. All right, I'll go to it. So today, very quickly, I'm going to skip over some stuff, so forgive me for that, but the answer to that is come to Melbourne in October for the ANZONA conference. If you're interested in going to the horse races, the Melbourne Cup, it's on, I think it's the weekend after, is that right? So yeah, you can come to the conference and then stay for the Melbourne Cup. So hopefully I'll be presenting there, and I'll be able to expand on this a little bit more. So today what I'm talking about is some research I did as part of my Masters. I'm currently employed at the University of Adelaide, where I coordinate the Orthopaedic Grad Dip program, or Stage 1 Masters. I was working in orthopaedics for the last 20 odd years, but I've just now moved to the uni full time, which I enjoy. But I do miss some aspects of ward work. Some aspects, not all. There's some things that are good and some things that are bad. So basically, I did some research looking at what orthopaedic nursing is today. Now, it wasn't about, just about, what an orthopaedic nurses do. Do they do traction? Do they put plasters on? It was a little bit more sort of conceptual view, I guess, as well. So it was a little bit out there, a bit airy-fairy in some respects. But there's some really good information that came out of it, some really, I think, concrete recommendations. So that's what I'll talk about today. So I'll go on to the next one. So that's just what I'm going to go through. The research just included nurses from Australia and New Zealand. It's not going to contain anything you're going to be blown away by. It all makes sense. It's all common sense. But it might just help organise it a little bit better than we as a group have maybe organised it in the past. So hopefully that will achieve that. And it might help you also appreciate some of the things that you sort of do automatically, that you don't really appreciate the value of what you do and the way you do it. So sometimes the way we learn things, we learn how to do them well and efficiently, but we don't stop and think about how we do it. And there's value in doing that sometimes. So Peter Davis, who some of you may know from the UK, once wrote, any specialist area of a profession has to continually define its position to justify and take forward its practice. And that's the same for orthopaedic nursing. There's value in stopping and looking at what we do, defining what we do, so we can therefore show the value of what we do to others. Because most of us here know that orthopaedic nursing is important. I think orthopaedic nursing is important. I think it's important for the group. I think it's important for our patients. But we need to be able to say that and say it well, so that other people hear the message and grasp the importance of what we do for our patients. And that's sort of looking at giving us a bit of a voice. So that involves a bit of introspection, a bit of reflection, and then justification as well. So throughout this presentation, I'll talk about orthopaedic nursing groups. And when I say a group, I mean a number of different things. So I mean this group, I mean ANZONA, I mean ICON, which is the International Collaboration of Orthopaedic Nurses, but I also mean a group of orthopaedic nurses on a ward, or a group of orthopaedic nurses in a hospital. So there's a whole bunch of different groups of orthopaedic nurses. And that sort of complicates things a little bit, but that's how it's set up and that's the way it works. So that's okay. For the research, I looked at the history of orthopaedic nursing. It was really quite an interesting thing to go through. You might not be able to read that cartoon there, sorry. But it was deceptively valuable having a look through how orthopaedic nursing has developed over the number of decades that it's been going. It's a lot different to what it used to be when it first started. Some things are exactly the same, and there's some value in knowing that as well. So orthopaedic nursing's changed. It's been moulded by a lot of different external and internal influences as well. So it's been moulded in response to changes. It's a lot of those, well, probably primarily from changes in surgical management of orthopaedic patients, really. But there's a number of other things that influence healthcare and society. And some people might think that changes and all that good, for our group. We need to sort of stabilise it out, but we need to be a bit flexible and dynamic in how we manage the group and how we act as a group, because if we don't do that, then we might become irrelevant and then we cease to exist, I guess, worst case scenario. So it's up to us as leaders, and most people in this room are leaders. I think they all say, just by being here and being interested in this sort of thing, that you're a leader to varying degrees, and so we can influence the direction that goes. I won't bore you to death with methodology. I can talk for hours about ethnography, and you would sleep in about 3 seconds. But basically, ethnography is about learning about a culture of a group of people and how they act, what sort of things they share in common. So that's what I used as a basis. And a good example of that is what do footy players do on the field when someone scores a goal or they do something good? What's often one? Sorry? They tap each they tap each other on the butt. So if you're if you're a football player, it's okay to go up and whack your mate on his bum. If he was in church the following Sunday and his mate was there, would he go up and tap his mate on the bum? No, because it's a different group, it's a different setting, and that sort of behaviour is not okay in a church or wherever. But on the football field, it's perfectly okay, and there's nothing wrong with that. But it's about understanding what's okay, what's not okay, how people behave, all that sort of stuff. So it's a very rough example of ethnography, I guess. Now, I stole this from a PhD student, but hopefully he was happy with that. And his last words. This is just a way of representing what orthopaedic nursing is. So if you consider all of this is orthopaedic nursing, these 2 little areas here are very specific. So each of us in this group has different patient populations we look after. We have different roles, we're in different settings, different locations. But within that, is now looking like a bit of a face, isn't it? Within that, though, there's some common ground that we share. So we have shared beliefs, we have shared values and norms and patterns of way we provide our care. So this is the sort of area I'm interested in down the bottom here, about what's common to orthopaedic nursing. It's important to be aware of that. Ethics, I won't talk about that. I've got ethics approval and confidentiality and privacy is maintained, and we've got consent. So there was no patients involved, so it was pretty straightforward. The method, I'll go through it quickly again, very broad at the start, narrowly focused towards the end. There were 2 phases. The first phase was an online questionnaire, which some of you may have responded to, which was excellent if you did. In that, we asked about demographics of nurses, what sort of experience, what sort of qualifications, all those sort of things. Then there were some free-form questions, and then I used that information to do a thematic analysis, and then I interviewed a few participants and used those things to ask them questions and sort of get a deeper understanding of some of the things I'd identified in the first phase. So the things I came up with, knowledge and skills. So there's specific knowledge and specific skills to orthopaedic nursing. There's a bit of uncertainty about where we're going as a group, and orthopaedic nurses and around the world, that's common. But there was a bit of hope. There was a bit of positiveness, probably a bit more than I expected actually, which was good. Leadership focused very, very well in all the people's responses. And around that was promoting orthopaedic nursing as well. And then the members and patients had certain needs that the group was responsible for trying to achieve for that group. So as ethnography often tells a story, so this is the story of orthopaedic nursing group as in general. Orthopaedic nurses had a strong sense of self-preservation, but they had an overall positive outlook. So it's important to understand some of these issues to get a feeling about what orthopaedic nurses thought as a group. One of the big things that came through, that orthopaedic patients have unique needs, and we might forget that sometimes because we're so used to looking after orthopaedic patients that we sort of forget some of the things we do are really quite specialised and quite unique. And I like to use an example of a patient who's lying in bed in traction. Maybe they've got a pelvic injury and they're in traction, and you need to go and turn them over to do some pressure area care. What sort of things do you think about when you go to do something like pressure area care on that sort of patient? What would you consider before you did that? Yep, so, and that's related to their injury, what their injury is, how it's been fixed, what they're allowed to do. Are they allowed to roll? Do they need to be Jordan framed? Yep. Pain, yep, so if they had analgesia before. If they have, did it work last time? Was it enough? Were you going to give some more? Are you going to change it? You know, that sort of stuff. What else? Yep, definitely. So, and that's one of the themes you might be able to see up there. It takes more than one. And so, and that's only just a very few basic, you know, there's probably about 20 steps you think about, and often you think about that subconsciously before you go and do that. And the problem with that is, and that's fine, but the problem with that is if someone's standing back here and watching you do that, it looks easy. It looks like you can just go in there, you turn them over, you sort out their traction, you know how to handle the traction. They don't see it. It looks easy. And the problem with that is that if we don't stop and say this takes a little bit to do, you've got to think about this. There's more to it than appears. And people who make decisions about who gets, you know, where orthopaedic patients are placed might say, oh, they can just go to a general ward. They don't need to have orthopaedic nurses looking after them because it's easy. You know, you just go and turn them. It's easy. So they're the sort of things, and that's just a really basic example about what I'm trying to get across, I guess. So one thing I do encourage you to do is have a think about what you do in your practice. Think of one little example when you're providing care to a patient and write down every step you think about before you go and do that care. And I think you'll be really amazed how many steps there are before you go and do that. And the problem is if there's general surgical nurses trying to provide that care, they probably miss half of those steps because they're not aware of that. And it's something that orthopaedic nurses have developed over time and almost subconsciously to a level as well. Okay, so some of these things, what do orthopaedic nurses do? I think we know what we do, but sometimes we're not very good at saying it maybe. A lot of the fundamentals of orthopaedic care are the same, but even as the treatment of surgical treatment of orthopaedic patients change, some of the fundamentals still endure the way we treat our patients. Stuck in bed, that means our orthopaedic patients are not mobile. They're often stuck in bed. That has a whole range of implications in terms of what they need and what we need to do for them. And often they're in traction, and if you think about traction, that's like being restrained in bed. You're restraining a patient in bed, and all the implications there are around that. It's obviously for their own good, but they might not feel like it that way as well. More than one, so often you need anywhere up to, I've seen 6 orthopaedic nurses around a patient trying to turn them and do care, and that has implications for the way that we work as orthopaedic nurses. If that patient's on a general surgical ward, they might just try that with 2 or 3 nurses and it won't work. So there's that's unique as well. How we learn to be orthopaedic nurses, I talked a little bit about that as well. Other groups, so like physiotherapists, doctors, OTs, those sort of things, I won't go into that. The professional groups, so we've got a number of groups throughout Australia and New Zealand, and they depend on their engagement, depends on the group and how strong they are. Leadership is really important. It's probably one of the biggest factors, as I said before. If you have a strong or a weak leader, often impacts on how well the group functions, and that's quite evident sometimes. It's not hard to see, and that's one thing that I'll talk about a little bit later on as well. How someone becomes a leader is really important. How you inspire people to become leaders. If I look in this room, I don't want to offend anyone, but some of us are getting a bit older. So, how do we get the younger people, the younger generation, to come along and want to be leaders? How did that happen to us when we were their age? So, and things are a little bit different now, but we still need to consider that. That's really important. And that's about the long-term future of orthopaedic nurses. Not so shameless self-promotion. Someone said that in one of the interviews. You need a level of shameless self-promotion as a leader, and it is shameless in the way that you might be trying to big note yourself, but more often it seems to be about driving the orthopaedic group forward and also the care of the patient. So I don't think it's quite so shameless self-promotion, but that's how it can be seen sometimes. The passionate few, it falls to the passionate few sometimes. Um, in any group, there's always a sort of a concentrated group of people that do most of the work. So, and that's hard for those people because they're continuously working hard and doing all the work. So sometimes we need to stop and take a step back and see how we can involve other people in that and whether we can inspire them to do that as well. There are some concerns, I won't go through those, in the future mainly was around the specialisation and moves of orthopaedic patients to be put on general wards. How am I going for time? 20 past, right, I'll try and go fast, sorry. So some findings, there was pressure for change. The change is experienced differently depending on where you work, but overall there was a pressure for change in terms of how care is provided to orthopaedic patients. Sometimes as leaders we might not really fully appreciate what value we have and what the importance of our role is. You keep plugging away all the time, nothing's changing, and you're trying, you get a bit disheartened, but there's really, it might be a longer term thing, but there is real value to that leadership. And it's not just being about the leader of SAON or ANZONA, but it's about leadership within the group. And so I encourage you to hold on to that and don't lose heart. There's real value in keeping that strength of leadership as well. Looking at how the leadership, I've talked about that already, and also having an awareness of newer members of the group and how we can facilitate them into the group and how they can engage and become more part of the group and make the group open, I guess, to their involvement. So this is just more of the findings still. The role of the group, so like SAON and ANZONA are essential, so they need to exist, and it's really important that we focus on that because they act as a bit of a sort of a platform for us to engage on a quite high level and almost a political level, which is something I don't think we do enough of as well. And that's something in the past I've sort of thought, we don't really need to do that, but I think that's really important for us as a group. And it's a bit more, having that group is a bit more credence to, rather than two people just sticking their hand up all the time and saying things. If you've got a group saying that, hopefully people are going to listen to that a bit better and maybe take a bit of notice of that, because sometimes it doesn't happen. I won't talk about some of that stuff because I'm just repeating them just in the interest of time. I'll talk a little bit about education in a bit and also about engaging our new members. So I'll get into the recommendations. I'll split these up into education, practice, professional groups and leadership. In practice, it's recommended, and these aren't the same for every group that comes along. I just realised James is along, sorry. Hopefully James can hear us okay. Oh, is that you? Oh, take the thing away. That's a bit boring. Can you see? Hopefully you can see it now. That's right. So I recommend a number of those skills are called lost skills, or they're not used as often. Traction and plastering. They tend to get, plastering especially goes to outpatient areas, and so the staff on the ward don't get to put on and remove casts. And there's good reasons for that, because it's good to have someone specialised who knows what they're doing, rather than relying on people who aren't quite sure what they're doing. But one of the issues with that is then people will get de-skilled in that. So it's worth, if possible, rotating people through those places. Even if you just pick a select few, you can do that. And if the same goes for traction, if you're not seeing that very often, it's hard to keep those skills up. When I started orthopaedic nursing, I would see traction 14 times a day, whereas now you might see it once every 2 weeks. So you just don't have that same exposure to it. There's a bit of difficulty in role description, so there's a bit of crossover between what physios should do, what nurses should do, or what OT should do. I don't think we should be giving away too much to groups like physiotherapists. There's no reason. I think the staff say when I worked on the ward, wait for the physio to come to get them up for the first time. If you know what you're doing and you know what the injury is, there's no reason you can't get that patient up and start mobilising them. That's really important for the patient as well. And I think sometimes, as nurses and orthopaedic nurses, we underestimate the importance of our own language in the conversation. So that's about that, being aware of what we do and being able to articulate that, I think helps in that role. And probably the strongest recommendation for practice is that orthopaedic patients are in orthopaedic wards where there are specialised orthopaedic nurses. That pretty much goes without saying. Everyone unanimously agree that that's what should be the case. So that's a strong recommendation. Education, that's obviously very dear to my heart as being coordinator of a education program. It's really good and it's really valuable to have specialised orthopaedic nursing programs, postgraduate, but it's not the be-all and end-all. Some of the programs that are hospital-based are of equal value. There's people who don't want to do postgraduate study. There's enrolled nurses. For a number of reasons, you don't want to exclude them from being aware of orthopaedic conditions and how orthopaedic nursing works. So the value of hospital-based programs is really strong, and that's why programs like the what's it called here? Concepts, sorry. Concepts here at the Royal Adelaide is really valuable, and I'm glad Gavin's keeping that going. And that's available to staff from other areas. So if there's anyone else who's interested in that sort of thing, I don't know if they're probably closed by now, I think, but be aware that that's offered on an ongoing basis. So that's really important. But having said that, postgraduate specialist education is important as well. We need to make sure that we keep that going. And that sort of exposes orthopaedic nurses to a higher level of knowledge and skills, and also it starts them on the leadership path, hopefully, and even involved them in some research. Leadership is invaluable. I can't talk enough about leadership. How well your leaders perform is so linked to the effectiveness of the group, and so we need to be aware of how we act as leaders and how our leadership's going, and challenge that if we think there needs to be a little bit of a change. So that's really important, and around that is mentoring and trying to engage others. So making sure that we're actively seeking to engage others and involve them in the group and bring them in and have a bit of a succession plan as well. And it's not just about being organised and making sure that you've got your education sessions going. It's a bit more strategic, I guess, than that as well. So it's good to be that organised, but we need to think a bit outside the box a little bit and move to that next level. Professional groups, recommendations that each area obviously have them, and most areas do, but there's some areas that don't have any groups, like Tasmania and Northern Territory. But hopefully with some of these, if we're allowing people to have access by the internet, that may engage them a little bit more as well, so we'll see how that works. For the members, it's really important that we as a group and as leaders engage the members. So that means that we talk to them regularly, we email them, we let them know what's happening, we listen to them, we use ways that they find easy to engage with us. So whether that's using things like Facebook or other social media sites, having face-to-face stuff, having online stuff, recording information, all those sort of things we need to think about and try and improve that contact with our members. Because the more members we have, if we had every seat filled here, it would be fabulous. And there's so much more engagement, there's so much more possibilities with more people. So that's really a big area that we can focus on as well. Rural members, I think, warrant special consideration. That not only are they disadvantaged by distance, they also often are working in areas where they're the only nurse that's really passionate about orthopaedic nursing, because they're working in wards that see 700 different sorts of patient populations. Probably not that many, but quite a few. So often they feel a little bit isolated, and they don't have a group like this to sit in and ask questions and develop relationships. They're also looking after a wide range of orthopaedic injuries, so they're not really specialised in one area, and they don't have the ability to go and ask someone else who's maybe a bit more experienced or knowledgeable about that area. So they've got unique needs as well, so we need to listen to them and work out what they want as well. And maybe develop some specific education stuff around them. Future research. Sorry, I'm trying to get through this pretty quickly. So I recommend some future research, mainly around 3 different areas. Clinical research, so focused on what difference orthopaedic nursing makes. And a really good example of that is a study by Amy Hommel in Sweden. Oh, I forget where she's from. She looked at orthopaedic patients being nursed on wards with orthopaedic nurses and in general wards, and measured the differences in length of stay and complication rates. That sort of thing is excellent. You can use that information to say, okay, you want to put orthopaedic patients out in general wards, this is what will happen as a result. That sort of clinical research is really valuable, and I think we should be aiming to try and do some more of that. Repeating this research, someone can do it bigger and better, I'm sure, and there's value to that as well. And including patients and other disciplines in research is really valuable. And that's one thing I would have loved to have done, is at least include groups like physiotherapists, OTs, and patients if possible. But but I was limited by my time in terms of having to get my masters done, so it was a bit tricky. And then what other thing I recommend as well is to develop sort of support groups or mentors who are able to help people publish or do research as well. So if someone feels, I don't have the skills to do research or to write a publication, each one of you has got a really good story in you that is worthy of telling others about. And even if it's not something huge, it's still valuable. So if there's some way we can promote that, that'd be good. Yeah. So yeah, that's one recommendation, which probably sort of aim at ANZONA level as well. So in summary, orthopaedic nursing is a strong specialty. It's better than you think. It's better than I thought when I started. But there are challenges and there are threats to it. So we need to be aware of those threats, and we need to react to those and be proactive to those to try and ensure that we continue on as a group. And that's how orthopaedic nursing has occurred over the last 5 decades. We've responded to the changes. We've been a little bit flexible. We've changed the way we do things, and that's kept us strong. So we need to continue doing that as well. So that's vital that we see that that need to change as an opportunity, not as a threat in some ways as well. There's a lot of changes in orthopaedic nursing, but the fundamentals are still the same. Our patients might not be resting in bed as long as they were, but they still do rest in bed. They still have lots of pain. They still have mobility issues. So a lot of those fundamentals are still the same. Don't let someone tell you they're not. They may have just changed a little. The focus may have shifted away a little bit, but those things are still the same. So it's really important that orthopaedic patients still need specialised care, and we need to be able to understand that and be able to articulate that to ourselves and then to others as well. So we need to make our value obvious, and we need to say it loud, and we need to say it long. And this was a quote from one of the participants. It said, "Orthopaedic nurses rule." I agree. So again, change is inevitable, but I see that as an opportunity. So it's something we should take the lead of, and we can help shape the future. That's a really fancy looking map, but concept map, looking at all the links. You won't be able to see any of that, sorry. And I'd just like to thank Rick, who was my supervisor. Anita, she helped me come up with the concept and was invaluable as a fellow passionate orthopaedic nurse. And Say on committee, who provided funds, kindly provided funds to cover some of the costs of doing the research. And ANZONA for helping access some of the participants, and especially the orthopaedic nurses and the participants. Without them, we're nothing, and I appreciate their time in helping making this research come together. There's a whole bunch of references. And there's, anyone got any questions or suggestions? That's, what are we calling him? No, it's Napoleon's, that's right. It was, I think Slim got lost. Yes, Bree. The research that's going to be done, or well, I've almost about 2/3 of the way through submitting to the International Journal of Orthopaedic Medicine. So that hopefully will come out later this year. I've split it up into 2 parts because it's being a bit selfish because I only get 2 publications out of it, hopefully. But it was such a big topic, it was hard to fit it all into one article. So I guess that's one way. So I talk about the 3 Ps: the publish, the promote, and the present. So I'm doing the presenting. I'll be hopefully doing the presenting in Melbourne, publishing, and then promoting, I guess, through the orthopaedic groups and through ANZONA as well. Yeah, yeah. Yeah, 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 yeah. Oh, and I think that's, yeah, at that level is really valuable as well. I mean, the problem, I guess, with some of those things, they want to know numbers, and they want to know, you know, I can stand up there and say, oh, this is really good and we should do this. But if I can't say, well, if we don't do this, this is what's going to happen. And I can suggest that, but they might just say, go away. You know, that's whatever. No, it was just acute. I mean, with the masters, it's pretty focused in terms of time frame. So it was just acute care nursing. Although in the first phase, it could be nurses who worked in rehabilitation units as well. So, but it wasn't anything. But I think that's definitely a valuable point that Bree and you're talking about is, you know, how do we best make, and but I guess that's a discussion for us as a group to think, you know, how's the best way of achieving, what's the best way of achieving that. And maybe this is just like a first, well, not a first step. There's been lots of smart people before me that have done really valuable research, but maybe this is the next step on my journey. But if you've got any ideas about how to achieve that, then yeah, definitely it's something we need to focus on. That's it. So thank you very much.